Okay, I would like to introduce our next speaker, Patrick Burns, who is from the Economic Roundtable. I became a fan of the Economic Roundtable by searching about how signing people up for Medi-Cal can actually be very beneficial. When a resident came to me, I teach residents, and said, well, I don't know if this patient's really sick enough to have Medi-Cal. And I said, oh, you need to read Patrick Burns' report. Patrick Burns from the Economic Roundtable is a senior researcher. His background is in geography, economic geography actually, and also he's a UCLA person. His studies at Economic Roundtable involve homelessness, human services, public assistance, labor market, regional industrial change, housing, environmental sustainability, and more.
Thank you so much for letting me be part of your panel today. So the program that I'm going to be talking about is commonly called the 10th Decile program, and what it is a program by which we identify high utilizers who are homeless, who have some form of significant disability, who are engaged at local hospitals, either the public DHS hospitals or private hospitals around LA County. And so there's this period in which they, in their travels, they kind of engage in the health system, and a person there kind of helps us identify them and flag them and see if we can kind of bring them into a program, the 10th Decile program, whereby they get prioritized, kind of be brought up to the front of the line for the homeless, the scarce housing resources that we have available in LA County for persons that need housing subsidy, that oftentimes need case management and other services in order to kind of successfully get off the streets and get housed. So I'm going to talk a little bit about this program today. It is a housing first, harm reduction kind of model that we follow and that our team members all follow. And a lot of the good work of the program is carried out by a team, so if you don't hear me referencing right away, it's going to be mentioned at a few points, but when I'm saying we or I, it's really this team that carries out the 10th Decile project. So what we have is a kind of a current set of pilot projects and then expanded pilot projects that's grown out of the series of reports that we released on homelessness. The first one was called Where We Sleep. Back in 2009, this report came out as a cost avoidance study to get an understanding of, once you kind of link together all the different social service and health service and justice system and other records across different departments that are normally kept separate, what can we say about these persons who are experiencing homeless when they're on the street, and then also afterwards once they've been housed? What if any kind of stabilizing effects are there? Subsequently, there were some two other studies that were released that were about operationalizing the findings from the first study. It's these two are creating and releasing a triage tool and introducing that to kind of people in the social service arena into hospital staff, such that they can use this triage tool to identify those persons that are what we call in the 10th decile. And I'll talk more about what that definition is in a minute. And then lastly, we did a program evaluation study last year that came out that was looking at, well, for the first 160 persons that were identified using the screening tools, what were the outcomes for how they were served. Okay. So for the hospitals involved, they're just kind of shown here on a map. There's about 18 hospitals participating thus far. It's cast against kind of a backdrop of last known address before persons declared being homeless in the DPSS data. And so from these pilots, we've been kind of carrying out, or from these hospitals, we've been kind of carrying out pilots with different teams of housing navigators, FQHCs, and other partners as well. Now, our roadmap for creating a tool to identify our type of high utilizer, these are homeless, disabled persons that have very high needs and very high costs. Our first step in kind of creating the triage tools to help identify these persons was to go about linking records across different county departments here in LA County. The work was done in strong partnership with the LA County's Services Integration Branch of the Chief Executive's Office. And They've carried out a couple of these data linkage projects recently, sometimes for program evaluation, sometimes for fraud detection, and sometimes for kind of trying to make their overall county services more efficiently. But what we discovered is that once those data records were linked and you start to look at costs over in public health department services and mental health services and DHS and in probation and other different county departments, when you kind of add those all together, it was a very significant 10% once they were kind of ranked from lowest cost utilizers to highest utilizers. That upper 10% really stood out as kind of noteworthy, and so we focused on those. We went about then developing and deploying triage tools in order to help identify these people at points of service within public and private hospitals in LA County. And as part of that too, we went about carrying out some evaluation, collecting some information about these clients as they were identified, and so that we can kind of get an understanding of for different types of outcomes, what were the characteristics that may have led to that in the process. So there's kind of some ongoing evaluation that's happening as part of this as well. The different county records that we utilize, there's about 17 different types, covering from health services, public assistance and social services, justice system records, as well as housing assistance services. And so as I mentioned before, there's a 10% group, once folks are ranked from kind of lowest public cost to highest public cost, that is kind of shown here. It's dividing that overall state population into 10% groups, ranked from kind of lowest to highest costs. And then 10th decile, the highest cost decile, is the one that stands out in terms of especially healthcare costs and other types of social assistance and social service and public agency costs. These 10% with the highest costs accounted for 56% of all public and hospital costs amongst homeless persons that were studied. And it really is kind of indicative of kind of ongoing crises in their lives, cycling in and out of ERs and all that familiar stuff. Now, we also looked in that study at trying to understand what the cost difference was for persons that were out on the street versus those that were moved into housing and were able to find housing in their travels by engaging with social service agencies and nonprofits and advocacy groups. And so what we have here is kind of a look at for the different cost deciles, numbers 5 through 10 across the bottom there. The left half kind of shows the reduced costs that were found, monthly costs, after persons were placed into permanent supportive housing. And in particular, these were clients that were in Skid Row Housing Trust housing in and around downtown LA. The right-hand side shows the kind of cost difference between that amount that's shown on the previous slide for when people on the street versus once there's a reduction in costs on average in terms of per month, what that cost difference or avoidance or savings is for the different cost deciles there. Now, as far as our program goes, we've had some initial pilots that you can read about on our website. The first one was carried out initially with terrific funding from the Hillman Foundation, and it went about establishing some pilot programs at different LA area hospitals, California Hospital in downtown LA County USC, St. John's Health Center over in Santa Monica, and one or two others. And so that was the initial set of pilots that was going on since about 2010, and a few of those are still going on. But then a lot of them were kind of converted over under a new source of funding from the National Corporation for Corporation for National and Community Service, their Social Innovation Fund, to be expanded and be built up their capacity a little bit. And we have a set of partners that you can see there on the left-hand side that are kind of our housing navigators and kind of experts in terms of case management. And that program is also something that's kind of ongoing. It's in the ending its second year and heading on to probably 2 to 3 more years of funding and support. But these are just expanded pilots trying to build capacity and see what can be done with different local hospitals in terms of identifying some of their patients, both ER, inpatients, overnight guests, and clinic folks who are being served in different clinics and so forth, as they're kind of making that kind of those journeys back and forth between out on the street, where they're kind of coping with chronic illness, mental illness, substance abuse, and incarceration stints, and then when they find themselves in the hospital periodically. And there's a quick bar chart kind of below out there where we kind of look at what are some of the hospitals that have identified the most. These would be just inpatient stays for persons who are homeless. There are a couple of hospitals in LA County that don't identify their patients this way, but in the OSHPAD data, you can kind of glean where that distribution is, and you can see LA County, USC, of course, handles a big burden of those. What our program model does then is goes about kind of screening these patients with our triage tool, and also gets them engaged with case managers who help them kind of navigate services, first getting into temporary housing and kind of addressing some of their kind of immediate prescription and health and disability needs, and then also starting the process to, if needed, get into like SSI eligibility work, recovering IDs that have been lost or stolen, and also starting a process for a Section 8 housing voucher that can help subsidize the long-term unit that they'll move in subsequently. Ideally, within a period as short as 3 months, but often closer to 6 months, you kind of go through that process of the housing application for the voucher, and at the same time kind of establishing kind of a medical home for these different clients who are now having kind of moved out of hospital stay and are staying in temporary housing. And ultimately, once they get placed, kind of linking them with local services and local care providers too. And really, taking a step back for just a second, the program model that we have with the 10th Decile project relative to the ACA, which is, I know, kind of why everybody's here today, it's something actually we're still learning about. We're in the process of just trying to understand what the overlap will be in terms of some of the health services provided and other kind of support, maybe indirectly, of kind of case management services that help out homeless persons, and maybe kind of overlap into support for housing too, although that is maybe not likely. But we're still learning about those too, so we're not really coming as experts relative to the ACA. Now, in terms of persons that find their way into this category that we consider 10th decile, highest need, highest cost homeless persons in LA County, there's many different characteristics that can find you there. It can be many different age groups, many different kind of backgrounds in terms of your life trajectory, getting to this point where you've wound up in the ER and maybe multiple times this month and are kind of seeking care and will be likely discharged into the street again. So what we found in our earlier research was that no single characteristic, no one variable really in the data helped identify persons as to whether or not they were or were not in this 10th decile segment of the homeless persons that go in to seek care in LA County hospitals. At best, the strongest characteristic that we found was that about 49% likely that jail mental health stays or stints was the best predictor. But again, that's less than half the persons that kind of had that. So what that kind of left us in the position and the need to do is to kind of blend together some of the different factors that we might learn about patients in order to kind of get a better read on which ones are very likely to be that high utilizer, high cost, high need population. So we've made 2 triage tools over time. This first one is kind of represented here by a kind of a bubble chart that identifies the different variables, the data variables that help us identify whether somebody is in that highest utilizer category. And so we had in there that information about whether a person was in jail receiving medical services also, and was in jail and receiving mental health services. And those strong variables kind of allow us, as well as some others, to kind of limit the combination of data collected and used as an indicator as to whether or not somebody's in the 10th decile or not. limits that to about 27 different data items. And so that's good, but oftentimes when we're in a kind of a hospital environment, kind of for a patient to voluntarily give and accurately talk about kind of justice system encounters is really not that likely. And the hospital social worker, the nurse, or whomever there is not always able to get that information or get it accurately. So we made a second version of the triage tool that's also in use right alongside the first one. So for cases, for persons that come in where you don't know anything about their justice system history, we have to offset the loss of those important predictive variables with adding in a bunch of others. So the triage tool version 2 has 51 different data items in there. Everything from demographic information, whether or not they were born in the US or not, whether they were born in California or not, different things like that, combined with health diagnoses and number of visits within the past 2 years in order to kind of give a picture and accurately predict whether somebody's in that high utilizer category. So our triage tools are kind of based in Microsoft Excel. It's pretty basic in one level, that there's kind of a set of variables that you need to check off. Each one of these columns here in Excel would be a single person. So for that first column, you go off and check off either kind of putting in a yes or putting in a number of visits or the characteristics that a person might have. This would be the healthcare provider, staff person that would initially flag this and try to run the model. And so it would be the hospital social worker, maybe over at LA County USC, or maybe they might call us for one of the patient navigator groups in order to kind of get a read on it too. And if they have a certain score, then it identifies that they're in the 10th decile. And the model is also set up with distinct model, or excuse me, the triage tool is set up with 4 distinct models within it. So it's split by gender. And there's one specific model for women, and for men there's 3 depending upon age, because age plays a very strong role in the prediction as well. And then ultimately what we're trying to do, this is the sleepy part, is that we're trying to identify and estimate whether or not people are in that highest cost, highest need category when they happen to be walking into LA County facilities or LA private hospitals that day. And it kind of looks back at the last 2 years' worth and makes the best estimate while trying to kind of reduce the number of false positives and also reduce the amount of false negatives in that prediction at the same time. So that threshold point is what gives us kind of a score of 0.35 is what you'll see in the tool. So because the triage tool is one that it goes about looking at the past 2 years of medical health history and current diagnoses, it doesn't really kind of look forward, like say if you have a new condition that has just arisen, a new diagnosis that is likely to kind of guarantee high costs in the coming years. We do allow for that, though, that there's staff who are administering this can have a clinical override. So if there's certain conditions such as being diagnosed with HIV, chronic liver disease, and others that you see listed there, we know that these are persons that have a high likelihood of being in the high utilizer category for us, that 10th decile. But it's also something that the cost might not have fully emerged yet. So instead of necessarily saying that, well, they don't necessarily make the cut in terms of their health diagnoses and recent health visits, we actually know that this new diagnosis is something where they are going to be in there, and so they get accepted that way too, in addition to the past 2 years worth of history. So looking at the first 160 patients that have gone into this set of pilot programs at different hospitals around LA County, the acronyms that you see there, the FUSE and SIFT programs, are the acronyms linked to that set of pilots. A majority were men. You can see the different breakdown in terms of race, age, and ethnicity. Chronic physical disability was common amongst 90% of persons that were those high utilizers, and about 78% had some form of mental disorder, and about 53% had some form of substance abuse. So looking at where these cases from our first evaluation report, which is that Getting Home report that I highlighted at the very beginning, we drew our cases from these different facilities that you can see on the map. Of course, there are some ones that have been with our earlier pilots, LA County USC, California Hospital, but also we've been kind of expanding up into the San Fernando Valley too. So there's a few hospitals up there, the Kaisers and Mission Community Hospital, that are a part of it as well. And so when we were trying to understand what the outcomes of the pilots have been recently in terms of implementing this program model of prioritizing those highest cost, highest need homeless patients as they come into the hospitals, we found that we were able to, the 163 that were flagged by different hospital staff, about 131 of them were successfully identified as being in that high-cost decile. There's about 89 who were engaged in social services with our case managers. And then there's about 44 persons that were successfully have gained housing voucher, 36% placement in PSH units. But then the process too for identifying people in these pilots in this model is one too where there's also negative outcomes that in terms of the amount of time that it takes to get folks into housing units, first getting them from their temporary housing site into long-term housing placements. There's a significant, or there's some persons that are either dropping out because of incarceration stints that kind of happen, warrants get picked up, etc. In terms of also, there's some persons that were deceased in the process, particularly amongst the older persons there. And then also persons that just kind of go missing, or either kind of elsewhere in the county or kind of moving just to crash on the cousin's couch someplace else in the state, things like that. So talking about that kind of overall number of persons that go about getting into our program and then also getting housed after certain periods of time, it's kind of the cumulative percent where we start looking at about 13% housed and placed after 3 months and close to 50% after 6 months, and then after that period getting closer to kind of the full amounts of patients screened initially. And then in terms of cost savings, in terms of per year, it's very interesting in terms of the cost savings before and after being placed into housing. These are annualized costs compared to the earlier slide in the 2009 report, which is monthly costs. So you see a change from 67,000 when homeless and on the street, compared to about 20,000 when placed in permanent supportive or other long-term housing units. And what this amounts to is about for every $6 avoided, we have about $1 spent in terms of the additional costs of kind of subsidy and kind of local case management services. It's kind of very good kind of response so far. So anyhow, I think I've gone a little bit over time. I'll leave it at that. But we're very happy to be able to talk about that model we have and kind of expanded pilots that are kind of still ongoing. So there's some more information about it on our website, and feel free to contact us with any questions.